Welcome to the third part of our three-part webinar on advanced care planning conversations and capturing reimbursement. I'm Patty Smith with the Healthy Shelby Community Partnership in Memphis, and we're pleased to present this new information for you. In this segment, you will learn about the new billing codes for advanced care planning in both inpatient and outpatient settings. Our presenter is Sally Aldrich, registered nurse with extensive experience in nursing and nursing administration. She serves on the Regulatory Committee for the National Hospice and Palliative Care Organization, and she is Senior Advisor for Methodist Le Bonheur Healthcare in Memphis.
Hey everybody, it's nice to be here. As Jerry and I talked about, I get to do the fun stuff today. We're going to talk about billing and coding. So hopefully you enjoyed the first two sessions. And what we're going to get into today is the documentation and capturing the reimbursement. Let's look at documenting these discussions. Now remember, this is all very new for Medicare this year. So it's an evolving new system. And as Medicare learns more, as we learn more, as we get much more into this over the next year or two, some of this will evolve. So what you're going to hear today from me repeatedly is that this is what we currently have as far as information, and always stay in contact with your local billing expert as to how to proceed. So what we're going to talk about is capturing reimbursement. Now, as you know with anything, when you meet with your patients, when you do medical management, documentation is essential. This is going to be even more crucial for documenting an advanced care planning conversation. This needs to be a separate conversation from your medical management. So if you're working with the patient on their diabetes, their hypertension, their other illnesses, make sure you do the medical management and then you move into a separate conversation about advanced care planning, and that you document that separately. It will help your coders, it will help you with billing, and it's also a very different way to document. So what are the key points? What do we need to look at when we're documenting the conversation? We've not had real clear direction from CMS on this. They're a bit vague because I'm not sure they know exactly. But here are the things we've picked up so far. First of all, who was involved in the conversation? One of the nice things about the advanced care planning conversations is that it can be with family members. So identify who you're talking to. Are you talking with the patient directly? Are you talking with family members? Do you have more than one person in the room that you're talking with? As always, put your start and end time, not just your total minutes, but when you started it and when you ended it. And then get into what was discussed. As we talked about in the second session, what are their concerns? What are important to them? How do they want to live? How do they want to be treated? What do they want? What do they not want? So what exactly did you talk about? What is the patient's understanding of their illness? Not just how to manage their illness, but what is their understanding of the progression of their illness? Has a patient completed an advanced care directive? This might be a good time to discuss who's their healthcare decision maker. Has an agent been determined? Have we made changes from previous documentation? It's a good time to review. Again, get into patient concerns. This is a narrative note, and so there's lots and lots of richness that can be brought to this documentation and the narrative that you bring. On the next slide, there are some additional factors that I think you can bring in to add to the documentation. Did you provide any educational materials? Jerry talked about the different advanced directive tools. You may want to revisit their 5 wishes tool to flesh that out a little bit more, add things, take away things. Have you addressed spiritual factors with the patient? Are there people that they want to have included that you know about? Are there any reflections from the patient, personal reflections on their family, on their illness, things that they're afraid of, things that they're concerned about, things that they worry about, things they feel good about? And why is the patient making the decision that they're making? This is, again, the opportunity to let the patient talk about this. Why is this important to you? Tell me these things, and then get this written down. Again, we go back to, how does the patient want to live? See if we can get that in writing. It helps you really make this advanced care planning documentation totally separate from the medical management. Again, this is more about the patient as a human being, how they want to be cared for, as opposed to the medical management of managing their chronic illness. Remember this, other members of the practice may be seeing this patient on follow-up and subsequent visits. So these notes will also help members of your practice better understand the conversations that you have had. Again, these notes need to be detailed. These are narrative notes. These aren't checklists, checkpoints, fill in the box, fill in the blank kinds of things. These are going to have to be hopefully dictated narrative notes, either on Dragon software or dictated to a transcriptionist. Let's take a look at the codes. The nice thing is Medicare came up with just 2 codes for us to wade through, and both of them are time-driven. So you've got your documentation done. Let's go in and look at the coding. Again, this is Part B billing. There are 2 codes that Medicare developed. One is 99497, and one is 99498. Let's take a look at 99497. This is the initial conversation for their advanced care planning. So this is the first conversation that you have with them. Again, this may be at their annual visit that you do with them. This may be at subsequent follow-up visits, but this is the initial conversation. This is where you explain the advanced directive. You have your initial conversations around that. You may be completing advanced directive forms when you do perform those. And a physician or other qualified healthcare professional can code and bill for these sessions, and we'll talk about that just a little bit later. Again, being time-driven, this is the first 30 minutes. These must be face-to-face conversations with the patient and or a family member and or the patient's surrogate. So remember, the patient doesn't always have to be present for these. But again, it's the first 30 minutes. We can't do telehealth kind of visits. That may evolve in the future where you can have a virtual visit over video, but right now, Medicare is very specific that this does have to be face-to-face. What are we getting paid for these? Right now, it's about $86 for the outpatient visit, another $80 for the inpatient visit. Again, this is not, you've got to take into account your regional geographic adjustments on those fees, and then, of course, the 2% sequestration. So it'll be a little less than that. I think what we're experiencing here in the regional South is about $75 for outpatient visits, so it's approximately that. So the first 30 minutes, 99497. Again, if you get into a 30-minute billing code and you hit that magic 16-minute mark on the conversation, you can bill for that full 30 minutes on 99497. And then if you get into extended conversations, which is really helpful when you've got multiple family members and you're getting into longer conversations, if you get into an additional 30 minutes, you can bill using 99498 as an additional 30-minute extended conversation. Let's take a look at the outpatient setting. How is all this going to work in the outpatient setting? So first of all, if you're billing for medical management, you bill as you normally would. Then also bill on time-based conversations that you have for advanced care planning. The important thing here is don't double dip. Don't have your medical management for 15 minutes and think you can bill for that same increment on your advanced care planning. Remember, these have got to be separate conversations. So do separate notes. I encourage you to do separate notes. Again, it helps your coders keep that temptation of double dipping on that time thing. Now, here's where the incident to rule applies, particularly for the outpatient setting. So say the physician comes in and tees up the conversation with the patient. You can then, as a physician or practice provider, leave the room and bring in another one of your non-billing team members. I specifically think of an RN or a social worker, someone who it's in their scope of practice. They can continue the conversation. They can keep, say the patient wants to fill out their 5 wishes tool during that visit. You can bring in one of your staff members. You can step out. They can continue with the service without ongoing direct supervision from the practice provider. And then when they finish with that, you can come back in the room to sort of finish up the conversation. You can bill for that entire time that the non-billing provider was working with the patient. That becomes that incident to rule. And then you can bill for the 99497. So it doesn't always have to be the practice provider accruing that full amount of time. and considers what matters most in these conversations. If we're doing palliative care, hospice conversation, these are the conversations that really need to be documented, first of all, for your entire practice providers, but also these are the conversations that matter most. And again, this is new. Continue to work with your compliance and your billing experts to make sure that we're doing it properly. On slide 7, I've just repeated what we're doing, the incident 2. This is where I start the conversation. I'd like to introduce to you to Jerry, our nurse, and she's going to talk with you about your healthcare decision maker, some of the content within the advance directive. Again, I encourage you, make sure that this is a team member this is within their scope of practice. The one thing I might steer clear of nowadays is, at least currently in the climate, is don't have an unlicensed provider having these kind of conversations, not necessarily a medical attendant or an office worker having these conversations. You want somebody who is trained, and this is within their scope. Again, this is a really good use by physicians and nurse practitioners when their time is very compressed. If you can turn these conversations over to somebody else, they can help you with that. Let's take a look on the next slide about if you're in an inpatient setting. A lot of our hospitalists are having these conversations. Remember that multiple conversations can be billed in a single day. So there might be more than one provider coming by to see the patient, and it gives you the opportunity to have lengthier discussions. Separate conversations can occur with multiple family members throughout the inpatient setting. Again, these have to be qualified healthcare professionals to bill under Part B. We did get a little bit of clarification on that recently, where they gave us a listing under Part B or who they consider qualified healthcare professionals. We can have a physician, a nurse practitioner, a physician assistant, a clinical nurse specialist, as well as a nurse midwife. Those are all considered qualified healthcare professionals to bill under Part B for this. Now, hospice can also have, if you're a hospice physician, hospice physicians and nurse practitioners can also have these advanced care planning conversations, and often do, particularly when you have palliative practice consult services in the hospital setting. As long as the physician is an employed physician by the hospice as well as the nurse practitioner, and they are acting as the patient's attending physician, they can bill for these advanced care planning conversations separately under Part B using the 2 codes. Now, right now, we've also received clarification. Social workers that can bill under Part B are not really billing for this service yet. They're not really allowed to do this. Medicare only pays social workers when they are billing for mental health counseling. We were disappointed to hear that because we have a lot of social workers I know that do a lot of advanced planning work with patients and families. But right at this time, again, this may evolve, but right at this time, social workers are only allowed to bill for mental health discussions, not advanced care planning. Number 1 is, do these have to be within the context of an illness? Again, this is one of the nice things about this is this can be done early. This can be a part of a wellness visit with a patient. These don't have to be sick patients. One of the things we'd like is for our healthier patients to begin thinking about this much earlier. You may not have thought about it, they may not have thought about it, but these are conversations that need to occur early on in life. As with any of us, we know that life can be fleeting and life can change on a dime very quickly. So the best advanced care planning is when it is done early on. Many of us, as we know, have all had too many crucial conversations with families that are in a crisis in a hospital setting, and not always the best decisions are made when patients and families are under that much stress. So also, who's paying for these codes? Now, local coverage determination may vary. Some private payers are covering advanced care conversations. Just check with your local billing expert as to whether or not your managed care providers are paying for these. Again, this is covered under Medicare, but can vary from region to region and also vary from plan to plan. So check with your billing expert. Again, how much time do we have to spend? More than half of each 30-minute increment. So you got to hit that 16-minute. Medical management has to be greater than 15 minutes. The same thing with advanced care planning. It has to be an additional greater than 15-minute conversation. So to use 99497, you got to hit that magic 16-minute mark. Do the conversations have to be in person? Yes, it's got to be in person. Remember, we said we can't quite use telehealth yet. We hope to maybe be able to do that in the future. But the nice thing about this is it can be with a family member. The patient doesn't necessarily have to be present. Now, just as one little caveat here, if you're going to use that second code, that extended visit code, and you get into 99498, that's where the conversation has to go for longer than 45 minutes. You can't get by with using 16 minutes for the 99497 and then bill 99498 for the next 15 minutes. You've got to run over your 30 minutes and into 45 in order for you to use both those codes simultaneously. So just a little warning on that. And right now, too, we had a question come up recently, what if I had a group session? You know, it's a good thought. What if I had a group of patients that we wanted to bring together and we were all going to go through the 5 wishes and educate them about the 5 wishes? You couldn't do a group session and then bill each separate patient for that 99497. So not really at this time. Again, check with your local payers. But right now, we're not seeing group conversations being approved for that. On slide 10, we've got some other billing questions. What are the documentation requirements? Again, we started that early in this session, but be sure that you document your start and your end times. Those are very, very important. An additional note to put in there is also, has the patient or the surrogate or the family member been given the opportunity to decline? They say that that's an important thing to have in your conversation and in your documentation. And then again, the details that we went over early on. What's the content of these conversations? Again, these are lengthier documentation issues, but the narrative here is going to be extremely important. And then also, too, consider this. There might be copays. As with Part B, under Medicare, there are copays for the patients that have to be considered. So there is some cost sharing, except with that annual wellness visit. I think there's a 20% copay for Medicare patient. How much do the commercial payers reimburse for these? Generally, what we're seeing right now is a 1.5 RVU for that initial conversation, that 99497, and we're seeing about a 1.4 for the 99498. Let's move ahead to slide 11, and let's take a look at the office process that you develop, because this is where every practice is really going to be a little bit different. So what I would encourage you to do is get your entire team together and talk it through. Again, this is new documentation. This is narrative documentation. And how is this going to play out? Your clinicians are important to this because we can talk about the Incident 2 rule stuff, your administrative staff, but then your information systems and your software experts for your EHR are really going to be important. The devil is in the details in this. And let's move ahead to slide 12 and take a look at what details do we have to consider. But the main thing I want you to consider and talk through is, how are you going to get to this documentation? Again, we've stressed that these advanced care planning documentations need to be separate, they're narrative, they're probably dictated or electronically transcribed. So are you going to create a new tab in your software? You've got to be able to get to it easily. Your coders have to be able to get to it easily, and it has to be distinguishable for a Medicare surveyor to be able to say, yes, this 99497, 99498 is a justified code. So where are you going to put it in your medical record, and is it available? Say you want to meet with your patient again and you haven't seen them since your last wellness visit. You want to get to the documentation from last year and refresh your memory a little bit. What did you talk about? What do you need to follow up on this time? Is somebody else going to be seeing the patient this time? Can they get to the note and understand what it is that you talked about previously? Do we have a way to manage different versions of the same information? What if somebody comes in with an advanced care plan? How do we scan that up and attach that to the record? What if they come in with the 5 wishes? Is it an attachment? Does it live in the tab? These are things we're struggling with, I know, in the hospital system. When a patient comes in and an inpatient and they have an advanced directive, we scan and attach it to the record, to the EHR, but then how do the hospitalists and the clinicians find that scanned document in the electronic health record? These are things to take into consideration. And then also, too, if the patient changes their healthcare agent, we talked about one of our patients in the office scenarios who's divorced. Maybe he's mad at his wife. Maybe he doesn't want his ex-wife to be his healthcare decision maker now. Who is going to be the healthcare decision maker? So if we've got to make changes in that advanced care plan, how are we going to make those changes, and how are we going to keep that current? The next person that looks at that knows that they have the most current version. Let's look at slide 13, some additional questions in the office. How are we going to know which of our patients don't have a healthcare agent? How do we know that so that we know to maybe tee up that conversation? Do we have a way to capture that data? Do we have a way of identifying our highest risk patients? One of the things that's been fascinating to work with in the outpatient palliative care realm is being able to identify those patients that are the highest utilizers of inpatient days, or the patients that are the highest risk. Do you have a way to risk stratify your patients in the outpatient setting as well? Where are your gaps with this in your office processes? How do you track progress of these high or rising risk patients? Do you think your processes are reliable? Again, I mentioned in the previous slide, how do you scan and attach an advance directive? How do you find it once you've scanned and attached it? And then how do you update? Again, some people are choosing to do an additional tab in their EHR for notes, updates, documents. Sometimes that is the easiest way to get what you're looking for. Let's move to slide 14. Advanced care planning is really an ongoing process. I know we all like to do one and dones. It gets frustrating when we have to keep at this and at this and at this. But remember, life evolves. Life evolves for all of us. Our health continues to evolve. Chronic illnesses kind of pile one on top of another as we age. This is going to be a conversation once you start having with your patients that you will have throughout your entire relationship with your patient. It's a good time to reflect. Has there been a recent death in the family? Has there been a divorce? Again, we talked about, is our surrogate decision maker going to change? At each decade, we mark our decades on our birthdays, welcome to this decade, welcome to that decade. Maybe that's a good time to revisit because our preferences change with time. How we think and feel and what we desire in our 30s and 40s begin to change in our 50s and 60s, and they change again in our 70s and 80s. Those are good times to revisit at birthdays, wellness visit, those kind of things. And then as you watch your patients decline, ask yourself this question: would I be surprised if my patient were to become seriously ill and die within the next 2 years? And I say 2 years because oftentimes it's an easier thing for all of us to think about is, are we looking really at a 2-year scenario here? Are we looking at a year? It's really hard, I think, sometimes to prognosticate in 6 months, but ask yourself, would I be surprised if my patient became seriously ill and died within the next year or two? And then when your patient has had a diagnosis of a serious illness, if this is a serious illness, this is the time to really begin to have honest eye-to-eye conversations with your patients about, we know that difficult decisions may be ahead. Let me walk with you. Let me journey with you. Let me do what is important to you as you live your days. And then again, the documents. When patients are coming in for their annual visits or any time they're going to make changes, ask them to bring hard copy with them. That way you can scan in and you can revisit it all together and you can get the most recent hard copies. So to close, again, on our last slide, remember all of this is new. Here's my disclaimer. This is new. This is the first year of all of this under the CMS requirements, so documentation will evolve. Have your compliance experts on your team and your billing experts stay abreast of this so that you can also be rewarded for the time and effort that it takes for you to have these really important, crucial conversations. Special thanks to everybody that's participated on this collaborative. I'm particularly grateful to Baptist Memorial Healthcare, Methodist Le Bonheur Healthcare, QSource, and of course our backbone in all of this, Healthy Shelby. Good day. It's been a great session with you, and I hope you do well. Thank you.